Welcome to Roadmap to Residency. Hello everyone, I am Abjiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So whenever you encounter USMLE style question, you need to read the raw study first. This will give you an idea on what to look for inside the long question stem. So this patient also requires immediate treatment with which of the following medications. So the question stem is asking us about what additional treatment should be given to this patient. Now let's see what is the patient all about. So we have a 20-year-old woman who is brought to the emergency department due to intractable vomiting and abdominal pain. She has a several week history of anorexia and weight loss. The patient has well-controlled primary hypothyroidism, treated with levothyroxine, but has not taken her medication for 2 days because of vomiting. Temperature is 99.7 degree Fahrenheit. Blood pressure is 80 upon 40, so blood pressure is decreased. Pulse is increased, and respirations are 18 per minute. On physical examinations, she is mildly lethargic but oriented. Generalized hyperpigmentation is present and is most conspicuous over the face, neck, and dorsal surface of the hands. Urine analysis and chest X-ray are within normal limits. Finger stick blood glucose is 60 mg per deciliter. A 1 liter bolus of normal saline is rapidly infused and high flow IV fluids are continued. This patient also requires immediate treatment of the following medication: ceftriaxone, dexamethasone, dopamine, epinephrine, or levothyroxine. Now we can see here that the patient has maybe just a simple asymptomatic disease or just simple nausea and vomiting, and the patient could not take her medications. Now, due to the severe vomiting, the patient is under hypovolemia. But for hypervolemia, we have already given our 1 liter bolus normal saline and high flow IV fluids. Okay. Now, also we can see that the patient has a hyperpigmentation, and but the patient blood glucose is low, which means that the patient's cortisol, the patient's ACTS level is such a high that the melanocyte stimulating hormone is also being stimulated and the patient is undergoing hyperpigmentation. So maybe this is a case of adrenal insufficiency. So in adrenal insufficiency, immediate treatment with which of the following medications is actually required. So we need to administer the patient dexamethasone. So this patient most likely has acute adrenal crisis. Her history of hypothyroidism puts her at increased risk of other autoimmune endocrinopathies, and her weight loss and hyperpigmentation are suggestive of chronic primary adrenal insufficiency or Addison's disease. Now, in normal individuals, the adrenal glands respond to acute stress, okay, like initial surgery, with a compensatory increase in the glucocorticoid production. But patients with adrenal insufficiency cannot mount such a response. Adrenal crisis is characterized by severe hypotension and refractory shock, which our patient had. Associated symptoms include abdominal pain, vomiting, weakness, and fever. Now, in addition to the aggressive fluid resuscitation, treatment of adrenal crisis requires immediate glucocorticoid supplementation with hydrocortisone or dexamethasone. The treatment should begin immediately without waiting for the results of diagnostic studies, and the response is usually rapid. Now, whenever you encounter a question in even your actual exam for the step one, then you will go through a range of emotions in the question. There we can see the first part just tells us that the patient is having vomiting and abdominal pain. So you may think, the patient is having just a simple abdominal symptoms, and then you just go and then you read that the patient is having hypothyroidism and the patient is taking levothyroxine for that. Now, the most common cause of hypothyroidism in this age group is autoimmune disease, right? And then you again go on looking, and then you again see that there is a hyperpigmentation, and then you see that okay, now this is the adrenal cause, and then again you see that the other examinations are normal. So while reading the questions, you will go through a range of emotions, even while solving the question bank and also in your proper examination. So yeah, you need to be ready for those sort of range of emotion, those sort of emotional journey throughout your exams. So let's talk about Addison's disease. So Addison's disease is a chronic primary adrenal insufficiency, which is caused by adrenal atrophy or destruction. This is most commonly due to autoimmune adrenalitis. Remember, the patient has primary hypothyroidism due to autoimmune conditions. So that also puts her at a higher risk of autoimmune adrenalitis. Or if the patient was from low-income countries, the most common cause of Addison's disease is tuberculosis. So Addison's disease, autoimmune adrenalitis, is the most common in the Western world. Infective is, in the low-income countries is TB and HIV, and there are some other causes like hemorrhages. Okay, in case of meningitis, in case of diphtheria infection, the patient can go and to have Addison's disease. So this is just the simple our cortisol or the adrenal gland pathway. Here you can see that the corticotropin releasing hormone just stimulates the release of adrenocorticotropic hormone, but this also stimulates the release of pro-opioid melanocortin. So that's why ACTS is released, melano-stimulating hormone is released, and beta endorphin is released. The beta endorphin is used for the pain. Okay, so it acts on the pain, it decreases the pain. But the melanocyte stimulating a hormone with the ACTH is so high because of the decreased negative feedback from the cortisol. The melanocyte stimulating hormone stimulates the melanocyte, and there will be skin pigmentation. And similarly, the ACTH, since the gland is gone, the cortisol will not be produced and it will be high and high ACTH. But in order to produce ACTH, the melanocyte stimulating hormone and the beta endorphin is also produced. Okay, and the cortisol just provides negative feedback to the ECTH and to the CRH. And when this cortisol acts on the liver, it causes gluconeogenesis, and it will just inhibit the hypoglycemia. Okay, our patient had hypoglycemia, and if the patient has consistent hypoglycemia, then maybe the nerves, the tissues will go in a lack of nutrition, or the patient may also have a seizure attack, right? So we need to correct hypoglycemia as soon as possible. Now, adrenal insufficiency, so there are primary and there are secondary adrenal insufficiency. Primary, the problem is in the adrenal gland. If you have watched our thyroid disorder videos, then you can understand that what is primary, what is secondary. If the disorder is in the gland itself, then it is primary. Okay, so in case of primary adrenal insufficiency, the problem is localized to the adrenal gland, and it can develop either acutely or chronically, and it is the chronic form is known as Addison's disease, which our patient has. So our patient has acute upon chronic, right? Now the secondary is if there is disorder in the pituitary gland. If the pituitary gland cannot secrete the ACTH and all, then that will not release the cortisol. Okay, that the adrenal gland will not be stimulated, and there will be no release of cortisol. So what are the clinical features of Addison's disease? So in the skin, we will have hyperpigmentation, and we will have other low blood pressure, weakness, and weight loss. So, and then there will be some gastrointestinal findings, like in our patients, nausea, diarrhea, and vomiting. And also in the skin, there can be vitiligo, right? And our patient has adrenal crisis. Okay, the patient can also present with fever, syncope, convulsions, hypoglycemia, hyponatremia, severe vomiting, and diarrhea. So acute adrenal insufficiency or adrenal crisis is due to the adrenal hemorrhage or infection, or due to some illness, injury, or surgery in the patient with chronic AI. So if the patient has chronic AI, then he or she cannot produce adequate amount of adrenal hormones. And in situations of some surgery, which is a stress-induced environment where the cortisols are not produced, and the patient will immediately go into adrenal crisis. Or also in case of pituitary apoplexy, the person can go into adrenal crisis. Now talking about the clinical features, this person will have hypotension and soft nausea, vomiting, and abdominal pain. And there can be fever and generalized weakness, which our patient had. Okay, the clinical features. Now, the treatment is hydrocortisone or dexamethasone and rapid intravenous volume depletion. Now, talking about the treatment of adrenal insufficiency, so we have got primary or central or secondary. So in the primary, we need to initiate the glucocorticoid and mineralocorticoid replacement therapy concurrently. And if and we need to optimize the therapy through the dose titration. What should be the we will just start with the low dose, and we will just go increasing the dose, and we just see the response. And at one limit, we just carry on that response, or we just carry on that disease, that dose. And central, we just initiate the glucocorticoid therapy, and we need to access for other pituitary hormonal deficiency. For example, if the defect is in the pituitary and we see that the patient is having decreased level of cortisol activity, then we need to also find out that if there are any other glands involved, because pituitary is just the controller of the glands. Now, is the patient a female with persistent deficits in any of the following, like mood, energy, libido, or quality of life? If yes, then we also offer a trial of dihydroepiandrosterone diane or hormone replacement therapy or androgen replacement therapy. So if the patient does not have the symptoms, then there is no role of this replacement therapy. So does the patient experience a therapeutic effect within 3 months? Yes, then we need to continue the DHEA therapy. But if no, then we need to titrate the dose as needed to achieve a morning DHEA concentration in the middle of the reference range. We need to avoid the doses more than 50 mg per day. Okay. And if the response is okay, then we just continue that therapy. If not, we need to just discontinue the therapy and investigate the other causes of symptoms. So what are the typical adrenal hormone replacement regimens for the chronic adrenal insufficiency in adults? So we need to administer the glucocorticoid therapy for all sorts of patients. And the preferred regimen is hydrocortisone, 50 to 20 mg orally daily. And we need to administer mineralocorticoid replacement therapy for primary adrenal insufficiency. So we administer fludrocortisone, right? And we need to administer the androgen replacement therapy in case of females with persistent symptoms. Thank you for watching. We'll log in back in the next one, the next super duper concept. Thank you all.